Hello, everyone. Welcome to Thursday, April 20th, for in-person Minnesota Doctor for Health Equity event. You can hang out over there, Doesn't matter if we have a lot of chairs here. Please grab some food. There's some swag in the back. You definitely still have a couple of hours. If we're involved in that, please let us know. We'll go some more. My name is Kuru Pham. I'm the current president for Minnesota Doctors for Health Equity. I'm a med-peds physician. I work half my time at Coop Clinic, which is a primary care clinic in South Minneapolis, FQC, and also the University of Minnesota. I do a little bit of fiction here. But I'm so excited to have you all in this place together with us. We haven't had a lot of in-person events for Minnesota Doctors for Health Equity this last year or so this is a special place for us to be together. There's a couple of QR scans that you should check out. For those who are on the board themselves, could you raise your hand or stand up? So these are board members. They've been with me. They're my friends. They're my colleagues. They volunteer their work with us. So thank you for helping to set up this event. Give them a round of applause, please. The other person I want to say thank you to, who is also a board member, Dr. Ryan Jelenic. He worked at Hennepin. He was actually the one who was the major impetus of organizing this event. Fortunately, he had a fever to 103 yesterday. His fever is gone today, but he thought it was better that he stayed home. So I wasn't going to MC this event, so I was a backup hitter. So hopefully I can step up to Ryan's standard. About MD for Health Equity, I wanted to read our vision for the group, just so you have a better understanding of what the group is. So our vision: empower health professionals to use their voice, knowledge, and to influence to implement the inequities that exist in health in healthcare, while working effectively with their patients, health systems, communities, and decision makers to address health equity wherever they live, work, learn, and play. So, gun violence has been part of our lives for a long time. It's unrelenting. There's a lot of trauma involved in this discussion. I'm a learner at this event, so I'm very pleased to have some expertise to talk about this. So I, as much as many of you, just learning about it from an advocacy standpoint to a legislative standpoint, and to be a community member in it overall. So enough about me. We're going to jump right to Control Galloway. He began his career at Ramsey County in Child Protection Services, helping parents and caregivers maintain safe environments for their children. Later, he joined Catholic Charities as program director, where he led a program that served children who needed emergency shelter placement and served youth who needed treatment services in a residential setting to address their trauma. His current position is the director of the Next Step Hospital-Based Violence Intervention Program based out of Hennepin Healthcare. Control's passion for helping those in need goes beyond his professional work in child protection services and program director. As a Black male, he experienced firsthand the challenges that come with systemic racial issues. His upbringing in a loving environment created by his parents allowed him to see the importance of helping others. Their mission to help those in need instilled in him a desire to fight for those who didn't have a voice. We'd like to all to extend a very warm welcome, express our sincere gratitude to Control the time and leadership together, and hand the mic over to him.
Good evening, everyone. And just I'll get this out for those who know me. I hate doing public speaking. But this issue is very important because it's killing our community. So here I am speaking about this. So I want to talk about the Next Step program and what we do at the hospitals that we serve. So go ahead. So I was going to give a brief history about the Next Step program, and also I was going to call a honored guest here, Connie Rose, who was one of the first people to work. So you go to the next slide. So the Next Step program, we started in 2016 as a collaboration between the city of Minneapolis and Hennepin Healthcare. And they started as a youth-based program where they feel like they had to do something to curb the violence that was happening within our youth. And as they began to do their work, they realized they were missing a large portion of the population because a lot of folks were going over to North Memorial. So then they worked together with the state and they were able to go and migrate over to North Memorial in 2018. So we had an age limit from 12 to 28 for that lasted until about 2019. That's when I came on board in 2019. That's right before the pandemic hit. And then when the pandemic hit, and then with the murder of George Floyd, we just seen our penetrating trauma and all the craziness happening in our communities just skyrocketed up. So that's when we got together and we decided we just needed to get rid of the age limit. And we started helping everyone who was a survivor of a violent crime that came through our emergency departments. And during that time, we were able then to migrate over to Abbott Northwestern. And then now, just a few months ago, we're now at Children's Minnesota. So as you can see, the need for our support in the community is great, but we also are a small team. We only have 14 full-time FTEs with 6 part-time people to serve 4 major hospitals here in Hennepin County. Next slide. Why is this work important, especially through the hospital? Because this is an important time where we feel like we can intervene when folks are coming up to the hospital. Because we know someone who has been a survivor of a violent crime is more likely to go back out there and harm someone else. I always say, hurt people, and then I'll still model that I learned from my folks in Oakland. Heal people, heal people. So we have to figure out a way to heal people. Next slide. Again, as I talked about, our job is to interrupt that cycle of violence generationally, and that's happening especially in the community of folks who look like me. We have to figure out a way to figure out what are the root causes. Why is this happening? Instead of just putting a Band-Aid on that, we want to go and figure out what happened to people. We don't want to have any judgmental about when they show up. We don't want to know what happened, why they're doing this. We want to know how can we prevent them from going back out there. And as you can see, when the program first started in 2016, their first year in existence, the recidivism rate for people coming into the hospital was 36%. That dropped to 5% in their first year. We just redid the numbers in 2021, and it was 6%. So it's still low. And that's without the age limit. So the work what we're doing is working. Next slide. This is just our model. Again, like I said, we want to get in there and reduce people coming back to the hospital, reduce people being again re-victimized when they come into the hospital. We want to support them, and like I said, we got to figure out what is the root cause. Not just figure out, hey, this is what we can do and put a Band-Aid on. We want to get them to be self-motivated to change so that when they do go back out in their communities, they're not doing the same things. But also, we understand we can't, when they're going back out in the communities, we want to change their community that they're going back out into. We can't just give them supports and then put them back in the same environment. We have to change the environment. And that's why when people always ask me, is there a discharge program for the Next Step program? Like, no, it's a lifelong journey, because what happened to them is going to affect them for the rest of their life. So we want to be with them as long as they feel like they need us. Next slide. This again is just our approach. We get notified different ways through each hospital, either by a Zipit, which is the ambulatory app, or an email, or a text message to go out to our group. And it used to be we would respond within 30 minutes that we got that call. But now, as I told you, my team has grown. We're 24/7 and we're right at the hospital. So we can respond directly into the emergency room, stabilization room, and then we can also respond directly to the bedside. And there's 2 parts to our program. Like I said, there's the bedside and the hospital intervention, and then there's the community intervention that we do. Next slide. So, like I said, we respond to the hospital within 30 minutes. That's where we come into the stabilization room, understand what happened to the patient if they're able to talk to us, and then figure out what family is showing up to the hospital. And as you know, sometimes us as a hospital system, we put up barriers where we don't want people to come to the hospital. Well, we want them to come because we want to make sure we can able to help them understand what's happening to their loved one within the hospital system, help them process what's going on within their own mind so that they will go back out into the community and do something irrational. I can just tell we just did that last Tuesday, where we had folks show up and we had to talk them down and not going back out to the community to do something irrational. So that's why we always say, people say, why you want people to come up? So we can help them heal, help them understand what's going on. As soon as we give them information about what's happening to their loved one into the hospital, temperature they have goes down. And then we're able to have a rational conversation with them, help them understand that, hey, going back out there and shooting him is not going to solve the issue. This is just, again, how we call the teachable moment. We've changed it now to the golden moment, especially when we're talking about survivors of violent crime, where they're sitting up in, like I said, we respond to the bedside. So when they're sitting up in the bed in their rooms and their minds are going about like, damn, what the hell just happened to me? What is life gonna look like for me? They're angry. They don't have somebody to reach out to. That's where we're at. We're having that conversation with them. That's when we start changing their mindset. Like, no, you've been blessed to have a second chance. Let's figure out, what do you want to do? We know you didn't grow up to be thinking you're going to be shot. What did you want to be as a kid? What was your aspirations? How can we get you back on that line? And then that's where they start to change that process. I understand that we're genuine, because I'll talk more about, but we use the narrative medicine approach just to let them know, like, hey, we're here for you. We have no judgment. We're going to be your advocate. Let's get you back on a different path. And most of the folks who work in our program have that lived experience or actually live in the community. And I can tell you, every time I go into that stabilization room, I probably know who's sitting in that bed, unfortunately. Slide. Again, and then after all of that, when we were talking to them about that golden moment, figuring out what's going to happen to them, we start to build a plan of what life is going to look like for them once they discharge from the hospital. So we started to decide what are goals, what are some short-term and long-term goals that you need to feel safe to re-engage back in your community safely. Sometimes that might be, I need to move out of my community. I need to move to a different spot. That could either be I need to move to a different part of the city, a different part of the state, or I need to move out of the state. And we can help with all of that. Or that means I just need I want to go back and get my education. I want to finish either my GED or I want to go to college. I just need some support on that. Sometimes it can be short term as, hey, I got shot. I got a good support system, but hey, I need some help financially. Can you help me with my food and groceries? Can you help pay my rent for a month or two until I can actually go back to work? So it's just so many things that we can do. And it's always led by the participants, never led by us, because we are a voluntary program. And then this is talking again about some of our services and approaches that I was just talking about, how we connect with our participants. So, again, when I talk about, we want to change the community. Again, it's the hospital's job to heal our folks physically. It's our job to heal them socially, emotionally, and mentally. And these are just some of the ways we do it. And the motto is change your story, change your life. Truly believe you can change your story, how your story has been written, and your life is going to change. And again, like I said, when we meet people at their most vulnerable moment. That's where we have to sometimes educate our hospital providers, our colleagues. When people show up to the hospital upset, crying, screaming, and they're yelling, be calm, be safe. Like, who's going to be calm and safe when they just learned that their brother or sister or mother just got shot? Like, I'm not. I'm telling you right now, I'm coming up there and I'm going to be upset. I want to know what's going on. So we have to understand and show some empathy. Sometimes I think us of us who've seen it so many times, we just get, what's the word I'm looking for? Jaded? Maybe jaded. But we're used to it. But it's not normal. Being shot is not normal. So, and that's what we have to tell our staff too, like, being shot is not normal. So we're not going to have a normal reaction when people show up. Next slide. So again, just talking about, and I'll just talk about some of the challenges that we've had to address for our own hospital. As you can just know, the health system itself has a lot of systemic issues for people, especially marginalized community, especially people who look like me. And when you come in there, you already hear people say, why are we helping them? They're doing the same old thing. Or, they're bringing the violence up here. Now I don't feel safe. So we have to like challenge that and say, no, that's not, they're a human being. We have to dehumanize folks when they come back into the hospital. And sometimes when they come in, we are dehumanizing them again. So and I think a part of that too is just some of us work in the field are also having that secondary trauma that we need to address ourselves so that we're not projecting on other people when they're showing to our hospital. But some of the, like I said, some of the barriers, when folks show up to the hospital and they go through the stay room and they get all their clothes cut off, they used to be if they were getting discharged, they were discharged in a hospital gown with paper shoes, you know, feeling dehumanized when they're being discharged from the hospital. But now that we're able to step in, we're making sure people feel like they're humanized by buying them clothes, buying them shoes, making sure that they are able to get their IDs, keeping their car keys, because sometimes when the police want to gather evidence at the hospital, we just want to take everything and give it to the police without even thinking about the survivor. We're taking their keys, we're taking their IDs, we're taking their cash, their credit cards. How the heck are they supposed to get home when they get discharged? How the hell are they supposed to buy food when you're taking all of their stuff? They can't. So we've stepped in there and said, let's change that practice. Because that practice is only affecting a certain amount of people. People who are marginalized, who don't have the resources to say, hey, don't do that to me. You're not gonna do that to me. Next slide. Again, I had already talked about some of this. You go next. And then this is our narrative medicine approach. After we've gotten folks calmed down and de-escalated about what's going on with their loved one, then we start sharing a little bit about ourselves and how we were able to make through adverse situations and why we are doing this work. Because I can tell you right now, if you're phony about what you're doing in your approach, people will see that right away and will turn them off. That's one reason why we stopped using the word victims and we use the word survivors. And I believe that is all I have for the Next Step program.
Thank you so much for sharing your stories with us. The work you're doing is so important. Like you, I don't like public speaking either. The only time I usually hold a mic is that I do karaoke at my home. So, yeah, this is a little awkward for me too. So thank you for doing that. I'd like to also introduce Susie Emmert. She's also a board member on MD for Health Equity. So quickly, I'm just going to introduce her. She's the Senior Director of Advocacy and Public Policy for the Healthcare System. Susie has worked in advocacy and public policy for over 13 years with an emphasis on Medicaid and public programs. She's been an advocate for gun violence prevention since her life was first touched by mass shooting over a decade ago. In her personal time, she is a board member of Protect Minnesota, a statewide advocacy organization working to prevent gun violence. Susie has been working with this session to support healthcare systems to advocate for those consent proposals. Susie will share what is happening at our state level and how we can influence the direction of gun violence prevention federal levels.
Great. Thank you so much. Thank you so much, everyone, for having me here tonight. Before the pandemic, I did like public speaking, and I didn't even need notes. I could get up here and tell you everything that was going on, but I'm a little rusty, so please be patient with my notes here. So, as you mentioned, a lot of our work right now at the state capitol is on several of these gun violence prevention bills. I'm really proud to be working on those this session and to actually report really positive action. And then we haven't gotten to do that in a long time. So I'm really happy about that. Last June, following yet another horrific event, the health systems, many of you work in health systems, our health systems came together and took a position finally on gun violence prevention. And we won't go down why in the world it took so long, but we're there. We have a position on gun violence prevention. I'm not going to name all the health systems that came together because I know I will forget some, but the folks that do my job, the folks that represent those health systems at the state and federal level, we were like, awesome, let's go. Like we needed that kind of green light in order to be able to go and talk to elected officials and say, NFN Healthcare wants you to pass a red flag bill. And we could say that and we could write letters and talk to lawmakers. And so that's exactly what we've been doing, along with a million other things if you're watching the news. So that really opened the door for us. What we did not anticipate was an election that would open another door for us in Minnesota. So in our work, we call that a policy window or a policy door. You do a whole bunch of work, no matter what, no matter who's in office. And then sometimes that election swings a door wide open that you didn't think was going to be open. And what that also did is that got the attention of folks at the federal level, like Every Town for Gun Safety, Giffords, Brady, all of those folks. And then they put a lot of money into Minnesota to pass some bills. So Moms Demand Action, which is part of Every Town, they are awesome. You gotta have moms at all your events. But so they poured a lot of money into Minnesota, and with, as you mentioned, I'm on Protect Minnesota's C4 board. And so poured a lot of money in, and we were able to really invest in boots on the ground, invest in lobbying support, really entirely focused on getting these bills passed during this really historic opportunity where we have a governor and a House and a Senate that are all aligned on this issue. So in case you watched, maybe I'm the only one that watched the governor's State of the State last night, maybe other people did. This is my life. It's always like, I know everybody watched the governor's State of the State last night, right? And so he spent a lot of time on gun violence. I was really proud to hear that. And so with that, when the governor spends a lot of time in the State of the State in his address to the House and Senate and the people of Minnesota, and the leaders in both that House and Senate are there in the room, he is indicating this is a high priority for me and you better get it done. And that is exactly what is happening this year. And so some of the leaders there are taking this opportunity. Some of them have worked on these issues forever. They have, kind of sussed out who are the people that are going to oppose it. What are people's concerns going to be? And they've been able to address a lot of those this year. And we are thrilled about that. Some folks, who had concerns about, mental health and other areas, we were able to put language in those bills to help some of that. So to help ease some of those concerns that maybe prevented the bills from moving forward. So I'm just going to focus on two bills. There's a number of items in the bills around community violence intervention. There's a big pot of money in one of them, a smaller pot of money in another one, all of those things that we're figuring out. But and there's some other kind of gun-related items that will be good with safety improvements. But the two big bills that have been kind of the talk of the town forever are extreme risk protection orders, and also known as red flag, and closing background study loopholes, or universal background checks. And so where those are right now, ERBO, extreme risk protection orders, that is going to allow the police and members of people's families to be able to petition to remove a gun from someone who may be at risk to themselves or others. And then closing the background study loopholes, that will, even private sales will now need a background study check, but it excludes, I think, like certain hunting guns or something like that. Yeah.
Do you know if that bill is going to allow healthcare workers? So if I'm seeing somebody in a clinic who tells me they're suicidal and I know they have firearms, are we going to be able to act on that without?
You would need to go to the police and work with the police and give your recommendation on it. But then it's the police job.
There's some.
No, my understanding is no. My understanding is you would be able to go to the police, but it would still be the police's responsibility to petition. So they could say, like, they could disagree with you, but at least the tool is there now, or it will be there. Nothing is done until the governor signs it. I have to be really clear about that. So where things stand right now is we're at a place in the legislative session. I'm not going to get into the weeds on this, I promise. I have a really hard time not doing that. But where we are right now is these big bills are included on the House side as we want them to be. There's a little kind of foot in the door on the Senate side. And I just want to assure you, this is all strategic. This is all so that we can get these over the finish line. The Senate has a much smaller margin of Democrats who are going to be able to push this over the finish line. The House has a much larger margin, so they can put a lot more stuff in their bills. And if you all remember civics class, if you all remember civics class, these two bills will come back together. They're going to have to, work through their disagreements. They'll accept some things in one bill, not accept other things. And eventually they'll have one bill that's going to pass the House and the Senate. and go to Governor Walz's desk. And so a lot can still happen. Nothing is a slam dunk. You know, we absolutely need to keep the pressure on, and we are, however, have never been positioned so well to actually make some progress in Minnesota on these issues. Just a ton has happened this year. You know, the Minnesota Doctors for Health Equity has been writing letters and submitting those to the different committees. There have been healthcare workers testifying in every single committee. Control cringes when he sees my phone number pop up because he knows I'm calling to ask him to testify, and he begrudgingly always says yes, or he sends another awesome person from his team to testify. The Minnesota Medical Association has been all over it. They've been testifying at every single hearing. So there have been just so many people coming together like never before, and jumping on the momentum that we have right now. So we're really thrilled about that. So there is a QR code back on the table as well. There's a QR code that we pull together an action alert for you. Even if your elected officials, you know, are with you, you know how they're gonna vote, they still need to hear from you. They still need to know that their constituents care about this, because what do? They talk to each other too. And so even if they already support it, and you know they do, send them a note and say, thank you, we are so close, please keep the pressure on, make sure this moves forward. If your elected official is a Republican, absolutely, they need to hear from you. I don't think we'll probably get a single Republican vote. That's just a political reality. That's not necessarily, you know, even a partisan statement. That is a political reality with the way the legislature is set up right now. And so they still need to hear from you. Absolutely, 100%. There are a few senators who are in some challenging districts. They've been a little bit squishy, but we think they're coming along. All of these folks need to hear from you. So please use the QR code, look up who your legislators are, send them an email, make a phone call. The folks that work at HCMC here know that I never ask you to take an advocacy step if it's not critically important. I don't want to waste your time. I don't want to waste my time. I don't want to waste elected officials' time. We are asking you to do this because it is still so critically important. So if you can, scan that. And the other thing you can do is you can join the Minnesota Doctors for Health Equity Gun Violence Prevention Work Group. Brian and I have been working on it, and Hannah and lots of other folks, Ashley, others around the room. Please join that group if you want to be more involved with what Minnesota Doctors for Health Equity does. Another QR code is the Gun Violence Prevention Primer, and that has a ton of information that Ryan and Hannah and others have worked on. So who's raising their hand, and then I'm going to hand this over because I see you looking at the phone, and I know I have time to get you. Yeah. I'm sorry?
How long is a petition take?
Oh my gosh, you've asked me a detailed question. I will actually sit and look it up and I'll let you know. Yeah. Anybody else? Awesome. And there's gun locks back on the table I wanted to flag. Those are free to take. That same QR code is the link for how to get more free gun locks that you can distribute to folks.
Yeah, here are the names on the screen. You take out your phones, and you don't know how to do your QR scan, and you know, update yourself. But the gun violence primer, you'll learn a lot about the data that's going on here. This is for our website and ways to join for MD for Health Equity. I would say it's free to join. You get a newsletter with it. If you want to donate, which I really encourage you to do, it's open and inclusive to all folks. It's not just for physicians to join the group too. And it's a way for you to engage overall. And then the last thing, do the letter to the legislator. I'll do that tonight myself. So it's an opportunity to do action. Okay, so now we are going to do the panelists. Kendra, thanks for just hanging out here. Okay, the next person I'm going to introduce is the Minneapolis Council member, Elliot Payne. Well, Council member Payne attended the University of Minnesota, go Gophers. I'm a fellow Gopher, for a degree in mechanical engineering, and then went on to earn an MBA from the Carlson School of Management. He began his time in City Hall in 2016 as a member of the Office of Performance and Innovation, before representing Ward 1 in City Council. In his role as a consultant, he helped his team establish the behavioral response team, designed a small business portal to make it easier for BIPOC and immigrant entrepreneurs to launch and grow their businesses, and helped amend the conduct and license premises ordinance to protect renters from unjust evictions. We'd like to thank Council Member Payne for his time on this panel and lending his expertise around the policy around taking place around gun violence at the local level. Next person I would introduce is Dr. Derek Lombard. Care person and benefit healthcare. He completed his general surgery residency at Acton and recently returned from his surgical critical care fellowship in San Antonio, Texas. His main research focus is on injury control and violence prevention. Derek has numerous contributions to the body literature around surgical trauma and continues to shape the trauma response of medical healthcare. So also very appreciative of Dr. Lombard's time to join us with this expertise. So I have some questions that Dr. Dominic had put together. I'm going to throw them out there, but we're also open to the audience to ask questions too. So there is only one mic, so we're going to shift this mic around for you all, okay? And I think this is just going to be kind of a discussion with anything else, okay? First question I have is storytelling can be quite powerful. If you were to tell your story as it relates to firearm injury, what story would you tell? What impact has firearm injury had on your life? So, hand off.
I go first. I would say guns has impacted my life and my family because I have cousins, and I have nephews who are in prison because of guns. I have my closest cousin, 2016, February of 2016, he was murdered. His murder is still not solved to this day. So it has affected me greatly.
Let's see. So I grew up, and my dad had a bullet wound like right above his heart, and that was a hunting accident, as far as I knew in my childhood. It wasn't until college where my mom actually shared with me that he actually pulled the gun on her, and then decided he couldn't do that, and so he shot himself and attempted to shoot himself in the heart, but missed. And yeah, I guess that's my experience.
The experience I want to share is a little bit different. I don't, and throughout my years of training, talk about many of my experiences caring for injured survivors or those that don't survive. And so instead, I'll share a story more recently of my time down in fellowship, and I probably have told no less than a group of 3 about this, and most of them were colleagues that I've worked with. But I did my training down in Texas, and in a month from next week is the 1-year anniversary of the Uvalde shooting. I was on call at the hospital, and I guess the part of the story that I want to share, not about those that we cared for, is the response time of when we found out down in the trauma bay was about 20 minutes after it happened. The team, the hospital, had such a robust and swift response that they had helicopters with whole blood flying to the scene that touched down in 57 minutes on scene. More so in the hospital, everything stopped. OR cases were canceled. They finished the ones that were started, of course. Down in the trauma bay, we had maybe 15 pediatricians, all of the peds ICU docs, all the trauma surgeons, about 25 residents that pulled from service. There was just this shift, and so many people were there and ready, as we heard, upwards of 80, and over the next 20, 30 minutes, the number, as we got updates from the scene, just kept going down. 50 may come, 30 may come, and it went down. This is all public knowledge. 3 came, and I think looking around and feeling that helplessness of we are there to react to something. And you can't do anything more. You can't go there despite everybody saying, you know, yeah, I would go be on scene at that hospital that took a lot of the ones that didn't survive into the hospital physically and weren't able to transfer. But then also trying to justify leaving the hospital to then go home to my family who was still alive. And the guilt, kind of the guilt never leaves you. And then other people just didn't want to leave that trauma bay. There was good bonding, but at the same time, none of it was happy. That's something that kind of stayed with you and something I carry with me as I kind of reflect on those that do survive and the work and effort that everyone through the hospital puts in day and night. It wasn't really until maybe a month or two later, talking with a lot of the hospital and trauma providers, that recognizing how good they were at organizing and mobilizing just this massive effort. It's because they've done that multiple times in the past 4 years. Sutherland Springs, 22 dead. That happened. That was the hospital that responded. 19 dead, 22 wounded. So the fact that they were good at it because they've done it so many times is really, really frustrating. I was in awe at the time until you realize it was out of necessity that they were good at it, not just because they, wanted to be good at it. And that, I think, sits well with how we respond to firearm violence in general. That was longer than I wanted, but I had to sum it all up.
Okay, thank you for sharing that. The next question is, what do you think is the biggest challenge in firearm injury prevention for serving Councilmember here?
Well, I think Susie stole a lot of the points that I wanted to make. And I'll just say, because I was like, okay, what do I want to say in a panel like this? And I want to kind of focus my role as a policymaker on that lane. Even though I do have some gun violence in my life that I could share, but from a policy perspective, I'm a first-term council member. I ran for city council in 2021 after the murder of George Floyd. That's what inspired me to do this. I think council members of past generations were dealing with potholes as their kind of primary thing. And right now we just had another settlement agreement with violence that they're showing that on a 14-year-old boy. We have the police force is down significantly. We have a new bargaining contract that we need to negotiate. We have rent stabilization that's coming forward, like the housing market is a really complex policy challenge. And before I was a council member, I was a nerd. And so I consider myself to be kind of a wonky person when it comes to policy. And some of these really big complex issues have all of these like intersecting variables that really not like if you put a rent control on, it might lower the amount of new production. So maybe one of the things you can do is subsidize new construction. Like it's like you get spun into kind of like analysis paralysis around policy because there's not an easy answer to a lot of our hardest challenges. Gun violence is not that. There's an easy answer to gun violence. It's we need less guns, right? Like it's that straightforward. And so it's like, it's no longer about, oh, what's going to be this hyper complex policy solution? It's no, what is the political solution to make sure that we have less guns? And I was just talking to Mark before this started and was saying how, it used to be this kind of dimension of like the size of government that was like Republican versus Democrat. And you have all kinds of diverse opinions in between that. Now it's just kind of like, it is partisan. There's a party that wants there to be less gun death. And so we want to control guns. It's pretty straightforward. And there's a party that doesn't want that. And so that means we just need to vote those people out And so that's the path that way.
I would agree. I always say, I see this, that we as a society are choosing to live this way. Don't have to live this way. Until more of us who are in the same mind thought go out and start moving folks who don't think the way we think about gun violence, this will continue. So I agree with the councilman. There's too many guns on the street, too many access to it. You know, folks can build guns. So we have to say this is not a Second Amendment thing. This is, we have to get less guns. We have to get the guns off the street. It's about the guns. You have access, they have access to it. People, when they're upset, are gonna make irrational decisions with something they have access to. So, yeah, it's the guns. We have to get access to the guns limited. And we have to decide as a society, we don't wanna live this way anymore.
Adding to that from a slightly side viewpoint is, in addition to that, finding ways to convince everybody that's not only affected directly, but indirectly, that it's worth their time to become strong advocates for prevention of these injuries is, I think, another step to shift how we all view gun violence in our communities. Even though somebody can say, well, it's not my problem, or it's not affecting me, therefore it's not my problem. And I think a forum like this, finding people, providers, or just people interested in the public health side to sign on to that and add their voice, is these little small movements that continue to shift that we didn't see 6 years ago when talking about firearm violence and injuries. And look how much of a topic it is now on every news station, on every Twitter. I think just need more of it and more people to spread that information by it.
I think you all kind of touched on this with this next question, really, because but the question is really, what is the greatest area of opportunity, particularly for our office members, the healthcare providers, areas of low-hanging areas for intervention, in terms of partnership with the work you do or the things that you do with it.
I can start. So, as someone who spent their entire training in the trauma field is to react to something, to see something and fix it, a bullet hole, whatever. I now realize how helpless that is in the other side of prevention, that a lot of our folks in primary care are in charge of captaining. And I think that this really needs to take hold in our primary care clinics, talking about firearms, safe storage, unintentional injuries of children. I mean, this is all stuff that is not politicized. It's, do you have guns in the home? How are they stored? Are there children that have access to it? Adding in that, I have a 2 and a 4-year-old. I go over to my in-laws because my grandfather-in-law passed away, and I know that he has hunting rifles and an NRA sticker that I took out his car for him. And those rifles were in the bedroom because they were one of my brother-in-laws was going to take up hunting, and so of course I gave him my thoughts on safety classes, which he had not taken. He wasn't in possession of them, which was fine. But I was like, hey, my 4-year-old and 2-year-old can climb on a bed. I get it. They're unloaded. I get it. There's no ammo stored in the same room or even in reach of a child. Come on. Is it because you didn't think of that in the presence of kids, or is it because you don't care? Or is I just wanted to know because this is the first time when, with my children, that, you know, I've had to deal with that conversation. And I didn't think it'd be with my family. Here I am worried about play dates with friends that maybe don't share the same safety and prevention. And so I really think it's having conversations in clinics that we don't have time for and that we're not reimbursed for. That really is where we're gonna find the easiest way to prevent these. But how the system's set up, there's no way for that to be realistic, and I realize that, which makes it that much more frustrating.
Yeah, I'll agree. Like, I think one of the lowest hanging fruits is that education around storage, and like, there's a stack of trigger locks in the back over there. Those are very accessible, very affordable. People should know about them, know how to use them, and have access to them. And it's like a group of me and a few other council members got together, like, you know, really early in the term in 2022. And again, that was under split government. So the idea of having meaningful regulations around guns didn't seem accessible to us at the state level. And so we're trying to think about what we could do at the city level. This is not a thing we can really regulate at the municipal level. St. Paul's now actually, just I think this week, is introducing ordinance language around requiring trigger locks and other safe storage methods. I think that's one of those things that's accessible. It's likely to get challenged in courts. I'm a big advocate of doing things even though they get challenged, because I don't think that challenge should be a like, try it, fine, like let it court decide, but that doesn't mean we should do nothing. And in the meantime, we should make gun locks as readily available as possible. So that's something that we're looking into, is having the city put budget resources into acquiring some of these and handing them out, doing gun safety training. I was one of those people that grew up in a very active gang war neighborhood. Got a bullet through my bedroom wall as a kid. That was trying to debate which gun violence story I wanted to talk about. And I just was always very anti-gun growing up because of the conditions I was in. But like, I spent some time in my 30s, I decided to go to like do some gun safety training just so that I at least had that knowledge of like proper safety and use. And it was just really funny being like this like 30-something-year-old black kid or black guy at this like gun shop with all these like 12-year-olds, because, you know, for some of those families that have a hunting tradition, you just grow up with guns. And I mean, at least there's like starting folks young on that safety training, so you at least have those basics around, you know, don't keep a loaded weapon around, always treat the gun like it's loaded even when you know it's not, always check the chamber to make sure there's not a bullet in there. These are like, you know, for people who are very anti-gun, like, you're not usually exposed to that kind of knowledge. So it's like, there's an education piece that's very low hanging fruit. There is a storage, safety, and equipment piece that's low hanging fruit. And we have to go up from there.
Yeah, I would agree with everything they said, but I'm gonna go just a little different and say, showing empathy to folks who are surviving, helping educate folks that it's not a Chicago problem, it's not a Louisiana problem, it's not a Black problem, it's a societal problem. How do we change that? And working with and identifying and working with folks who are out there doing the work, helping, supporting the interrupters that are out there, helping, you know, bring their work up that we're doing, just, you know, making it seem like we're out there doing that work, supporting those folks. And I would say for my folks who work in the hospital, educate your colleagues and help them be empathy when they show empathy when people are coming into the hospital, their families. How do we break down those barriers so that people feel like they're being humanized in their work day, that moment when they're showing up at the hospital?
Yeah, I'm gonna ask one last question, then we're gonna open it up to the audience too, so whenever you're ready, let me know. So this can go straight to control, but open to all the panelists here. How can we do better as healthcare providers to support their care for people who experience gun violence or firearm injury?
I'll just say what I just said. Yeah, exactly what I just said. So making sure we're showing empathy when people come to the hospital, breaking down the systemic barriers that's in place for people when they're coming up to get care, educating providers when they're doing stuff that's not culturally appropriate, Don't be afraid to call your colleague out when you know they're doing something that's wrong, that's dehumanizing somebody, they're just re-traumatizing people in the hospital. Be that person, be that advocate for that patient when you know one of your colleagues is doing something wrong. Take that brave step, because every interaction that we have with people matters. Because that interaction, it might come back to help you, you never know. Every interaction that we have with people matters. You stepping in and having some empathy for that person, again, might say, hey, my life matters, somebody actually cared about me in that setting. And they can change their whole trajectory.
One way that moving forward and what I've been trying to do is be an advocate for next step in the hospital as a provider. As someone that has, whether you're, whatever rung of the hierarchy in the hospital you are, be that person that can make sure that there's less barriers in the way of the people doing the work so that they can have a better impact on the survivors of violent injury. And continuing to find ways to address when that's not happening and find solutions. And I think a lot of it comes down to, as an organization, our hospital needs better trauma-informed care training. And that needs to come from high up and be mandated for everybody to go through that, because it's not just, as I was asked when I wanted more training put into our new employee orientation. Well, maybe that's something that should be focused more towards the emergency department and the trauma and surgery teams. And I said, no, this is my point. This is exactly why this needs to happen, is because this is everywhere in the hospital. And it's interactions directly, indirectly, how people are treated, being transported, communicating in the pre-op setting and the post-op care setting, nurses on all floors, physicians especially. I feel as a resident, I got very tunnel vision into the injury and addressing that, and you're keeping your head to the ground. I think you miss out on a lot of the humanity because of the desensitization. What Cantrell said earlier at the beginning is it's not normal to get shot, and I think it took me a lot of years, more than it should have, to really feel that as not being just an overworked resident that is 2 a.m. another person's shot. It's not normal. It's normal for a trauma surgeon to see somebody with gunshot wounds, but that doesn't make it normal. That doesn't make it okay. And I think that recognizing that can help bring back that ability to not allow the dehumanization of patient service.
But open it to the audience here. Anyone with questions?
I just want to thank all of you, Kentrell, thank you so much for pushing forward what I believe is like an amazing work that I was blessed to, like you said, blessed to help start that. And Councilmember Payne, thank you for your tireless support of the work that we do in the community around gun violence. And thank you, thank you so much for having that empathy that, I really think working with people in the front lines, starting working, I've been doing this work for a couple decades. So, but here, just with gunshot wound victims, sometimes they can feel othered. I've seen that happen. It's re-triggering. It's triggering for the staff. It's triggering for staff who are like frontline workers. But it's also triggering for the young person, the older person, whoever's been shot, because they already are dealing with a really tough time. So I think that is really just important. And then in terms of, I want to just ask everybody if we could just keep working together. So it doesn't matter if you're like, a lay person or, or whatever, we can all push towards gun violence, reduction. people have guns and they're getting guns and kids are getting guns, and that doesn't make any sense. So I think if you're a business owner, let's push towards that. If you're, one of the men, I've done lots of work with you guys, push towards that. Whatever you can do in whatever lane, it's important. And so I just want to thank you all for that. And so I'm County Restoration Incorporated. We have, we do gun violence work across Twin Cities. We have healing circles that we do for victims, but we also have a violence prevention team of caseworkers, but we also have a team of violence interrupters on the streets, who are on the streets right now. I came over here because I wanted to really be a part of this conversation. But just, give us your support and let's all work together to end this violence. I believe we can do it together.
Work together. Behind it.
Okay.
Super quick question. Just what you were saying is you can get used to taking care of people who've been shot. It's still not normal for you, right? And so, the healthcare provider, your youth and trial, how do you take care of your own mental health and that of your team processing it? Because you can do it every day, but as a doctor who doesn't do that, you still never get used to seeing people die, people suffer. There's nothing normal about that. And as much as we can compartmentalize to provide all of ourselves for patients and their families, it leaves a lasting impact. So I can imagine what it's like to work with people who survive, or those that don't, gun violence. So I guess, how do you take care of yourselves and your team to process your own emotions?
For my team, we have a mental health professional who is embedded in our team, who is part of our team meetings, who is part of our debriefings, who is on call for my staff when they need to. We had that last Tuesday, when we had 4 people come to the hospital who was shot. And the next day we had a huge briefing about, how people felt. Because it was the first time for someone who seeing someone statement who probably wasn't related. So we debriefed about that. As far as myself, I do something entirely different. Coach, I coach wrestling out of Champion Park. I work out, and then I just focus on some of the young folks who are on my team, making sure that they are being successful there. It's just a different lane and a different thought process from coaching. That's what, to when I'm actually at work.
That's a good question. I actually thought about this question coming up. Taking care of a team as a newer trauma surgeon, I'm better right now than I was a few years ago at recognizing who may need that extra support of the team. We have off-service meeting surgery residents that rotate, and they're maybe going to the radiology or anesthesia or something unrelated in primary care that affects everyone differently. And so recognizing when to do debriefs and step aside and talk about what they saw and what happened has been helpful. I don't think it does enough. And I don't think that there's enough right now for residents to process some of that. Speaking from experience, I think as a resident, I would not repress, but I would push a lot of it down. I wouldn't talk about it. My wife's favorite response when I would come home, call ship, and she'd ask about when, would be fine. Whether it was good or bad, that's just fine, because if there's a one place that I didn't have to want to talk about it. I'd say I turned to alcohol more in residency than not unhealthy for that I have concerns about, but using that as a tool for decompression or processing. And I'm happy to say that that's not the case anymore. And it's much more in a social setting, and that's, I think, physical activity has helped, and also reorganizing my priorities. But I don't think that's the case for everyone, and I think that people can hide it really well and don't really know who is not handling it well until they get pretty far down the path, which I think everyone in this profession or peripherally that you may have heard of has likely done with that. And sometimes pretty good to know that there wasn't. So I think my answer to that is some, but not enough of what we're doing This kind of scratch the surface, mental health in regards to this types of injuries and that.
I just wanna put in a plug for resources that might be relevant to some of you. I'm married to a family doctor and my name is Rapid. I noticed when I scanned the bottom piece article there about better to your legislator, at the bottom of the template, there was a link for the bullet points project. So if you're not already familiar with it, it's out of UC Davis, but it's a 1 hour, and you can get CME for it and it's free. So that's another good reason, but it's a training for basically how to talk to your patients in different clinical scenarios about firearms, whether it's, you know, the potentially suicidal patient, a patient with impending dementia, and your patients, a pediatric patient. And then also just encouraging anyone who works in a clinic setting, especially to think about how you can not only incorporate it into just your regular business having the conversation, but also to give resources. Some of you maybe are doing this already. I started a while ago distributing trigger locks in my clinic. I got mine from Protect Minnesota, and there are ways that you can get those and encourage your higher ups in your clinics to make that a doable thing for you. And there are groups that are working on that. So if that's something you are interested in, yeah, maybe more about that. We'd like to do that.
Thanks for sharing all this.
Thank you so much for sharing and for humanizing the issue of gun violence. For breaking it down too, so that we can feel that we can do something. At times we take the approach of it's not in my backyard, or what can one person do? But you know, in Africa we say that you don't know the power of one till you had one mosquito in your mosquito net, right? So just an appeal to all of us to do what we can. At times we think we are powerless. We don't actually think that we are very powerful, right? So Dr. Lambert, can you tell me a little bit about the trauma-informed care and how you can make a case for why everybody should go through that training in the care system? Thank you.
I think my case for why everyone should do it is me witnessing how communication is handled in the hospital. And I think that this is not something recent. I think this has been going on for decades, longer than I've been in practice, or even thought about becoming a doctor. That there's a lot of racism built into hospitals and how care is provided. And I think that talking about it and the presence of it isn't enough. And I think that those were great talking points in the years, and I know you're nodding your head, in the years leading up to even just the past decade, but how we're communicating with patients and how we're re-traumatizing when we're saying, you know, instead of like, hey, how did this happen? Or it's hey, who did this? And it's bringing a lot of these ways of more interrogating rather than caring for them. And I think the whole approach of supporting patients in a positive way, and even in communication at the bedside, and the microaggressions, the indirect nonverbal communication that's provided. I think that there's a lot of ways to improve it, and if you don't see it, it's just
Just I want to open that question to either you two or any comments about that trauma-informed care.
So I'm obviously not a doctor, but my wife is a cancer patient. And so I have that patient side experience. And I just remembered, so she got into a clinical trial at the University of Minnesota, and it's like the worst day of your life, you get that news, and you're just overwhelmed. I was telling somebody, I like read the Bob's Express book, like overnight the night she was diagnosed, because I just couldn't sleep, and that's how I processed that trauma myself. Okay. I don't normally talk about the moment, it's been 7 years, so I've heard the better side of it, but I just remember the clinical trial nurse, just, she had a protocol she had to follow. And it was, and like my wife had to get multiple biopsies because they didn't get it. It was a mess, right? And I just, that was like one of the hardest points of the treatment path. And then I remember we got a care coordinator who just was a human and kind of recognized where we were at. And wasn't like, okay, you need to get this test and that test, and then you got to follow this protocol. And just being able to slow down and recognize that, like, and yeah, I can imagine what it's like. It's like, if you're an oncologist, it's like, how many people have you seen go through the worst experience of their life, and how sensitized do you get to that? And I don't know what the right advice is to like resensitize yourself to that person's worst experience of their life, but that slowing down and just kind of recognizing what's going on, just being able to have that moment of pause and empathy before you start, because there are like really important clinical steps that need to happen. But that slowdown really helps. And I'm not a medical professional that's been formally trained in trauma and long care. It's just a life experience I've been through. And I just remembered that difference between our care coordination nurse and our clinical trial nurse, and how the care coordination nurse was able to just kind of step in and just be human with us and kind of put all the clinical discussion on pause for a brief moment. So.
I'll just echo what those two were saying. I would just also say, again, because we're re-traumatizing people as they come into the hospital, we need to change the questions from why are you doing this to what happened to you, and to change it from you need to do this to how can I be helpful. Just changing that mind frame will stop some of the re-traumatization that people are receiving when they come into our hospitals.
Sharon.
Hello, this is a question for our panelists and anyone else who has an answer in the room. I am one of the primary care docs who wants to be, well, I am doing some work on identifying firearms. It's easier with young children at their well child checks. What I'm looking for is when I see youth that I think are at risk, I want to get to them before they get to, not youth council member, but the other two. And how, I know that there are instructors out on the street, but if I'm in the exam room and I want to get somebody connected with a program that does help with instruction, do you have any suggestions of how that happens, or how to make a referral from the primary care office?
I will say, if you're at, if you're at one of the hospitals that we serve, which is ACMC North, Abbott, Children's, I would say you would refer them to us and we would help them.
Free buckets.
Free.
Well, I'm not, I'm in a community clinic in South Minneapolis, but.
I would still say, because we have connections to the city, I mean, we have county's organization here, it doesn't hurt. People call us all the time. If, just because someone wasn't shot or they come through our ED, still make the call, because we can make a connection to an organization that can help. Like Connie mentioned, it takes all of us. So just because they weren't shot, because you're right, that is the next evolution of our program. I see is to start going into the community and schools and figuring out who is affected by this disease before they get to us. But I'm with you. I like to get to them before they come to us in the hospital.
Yeah, what you're bringing up is primary prevention, and that is an area that I think there's a lot of interest putting. I do some research with Next Step and with just gun violence in this community and some national databases. Finding a way to shift from, let's prevent someone from getting re-injured by a firearm, to how do we start talking with families that may have generational violence and find ways to make an impact there before they get to the hospital systems. Get back to my reacting comment where I'm in a box and I only see you when something happens, and stretching out through Next Step and through people in the community, finding good resources and ways to roll those lifelines out in the community to do exactly what you're saying. Because I can't imagine how many physicians and providers in the community setting have seen something in their clinic that has tipped them off or a red flag of a concern, but they have no way and no resources right now to alert somebody to say, hey, like, let's do something about this. And I think that that's the natural evolution, like Michelle said. But right now, there's just nothing that I know of that's streamlined to get from point A to point B. So I have no help from you. But that's an area that I think a lot of people in the trauma community have started. They've done.
You gotta work.
There's a lot of people that have done much more research than I have that are starting to do that with community violence.
What I'll add to this is, I was around City Hall when we started the Office of Violence Prevention. Office of Violence Prevention is what led to the Next Step program. And the idea behind that was bringing a public health approach to violence prevention. And so what we've just done today is planted a seed for how can we expand that program, because this is a city funded initiative and it's been institutionalized in our structure of government that we now have an Office of Violence Prevention as part of our comprehensive approach to public safety. And I wasn't necessarily seeing the hospital setting as a place for that work outside of the Next Step program. Now you've just introduced an even earlier intervention than what we have right now. So that's going to be something I bring back to City Hall.
We got docs here from at least 3 Minneapolis community clinics,
Yes.
probably more.
And the city did have a program, it was for children, where they were working with younger children. Does that program still exist?
Yes.
Yeah, because the work at the city actually started out with health abuse development. That's how that early work started before they started working with older people. And I know there was a program at Tubman where they would work with kids that were referred to schools. But you're right, though, it's a lot that can happen in the doctor's office, and really that critical time is between 8 years and 11 years old, where you really need to start having those conversations about how whether kids feel safe in their home. It's not really just that yes or no question, but the conversations. The problem is doctors are held to this 10-minute to 15-minute appointment, and so how do we build out those things? It's really the challenge.
Hi, I'm Kosek, and I'm a third-year med student, and I wanted to kind of really bring that conversation back to people themselves, and really to go back to impress point on as a societal issue. And there's no one that's not there. And I've spent my past 2 years at the campus where I was facing different Native and communities, where I was taught to ask about gun safety during long-term visits, and that's a great thing because everyone has access to guns, and hunting is a great common. But despite having those safeguards in place, there are disparities that exist when it comes to suicide due to gun violence, children's health, unintentional injuries due to guns, and that's a huge disparity for moving service. So my question is, looking at the great programming that are happening with the Next Step, has there been any efforts to collaborate with rural and soil communities to build some of the community-based interventions and the realm of them?
best I can. To your point, I think there was a conversation that, we're having, I was at Technical Soda, someone asked me how to have the next step out in rural communities. Can like my team go out there, right? And what we talked about is, yeah, it'd be great for them to have their own program, but it should be folks from their community, because, you know, folks from our community live down there. So they could start an HFIB up there, but it should be run by folks who are ingrained in their community, because they would know it better than we do. But I would agree with you, because, you know, from what I hear, suicide in greater Minnesota is very high.
Yeah. 2/3 of gun deaths in the state are from self-inflicted injuries. And we don't, in the southern part of the state, see that. And I think, you know, Dr. Nygaard and I are doing some research in this area, looking at those that have self-inflicted firearm injuries, trying to look at, are there other signs through various databases, through previous admissions to the hospital, that can give a better idea of the risk factors that can lead to this, because I think it's a bad enough problem that I think everyone's looking for solutions. And like you said, asking about it in the clinic isn't fixing the problem. But hopefully with some of the new legislation, we could start making positive change in the acute setting of someone that should not have a firearm. But that's a whole topic on its own to be able to start to address. Fortunately, it's really focused to the north of the Twin Cities. Happens everywhere in sort of like in larger groups.
I just wanted to answer your first question. Oh, okay, so I just wanted to answer your question. And Corey, you talked about that program at Tubman's called Inspire Youth, and it's still going on. But at the end, I just want to quickly shout out Corey, because she didn't tell us, but she's a trailblazer in this work. She's the director, retired, from the Minneapolis Public Health Department, and started that work. The Office of Violence Prevention started Next Step, you know, was the one who provide that catalyst. So thank you for, you know, being the trailblazer. I just want to say, Dr. J, what you're doing is spot on, and our agency is available. We can take referrals. We have not only the violence interrupters on the street, but we have case managers, mentors. We have healing circles. So I'll give you my information, and if you want to have flyers out, or you want a referral, we have a referral process, whatever we can do to help. But there is a book called the Minneapolis Streets Directory. Am I getting that right? Yeah. Havoc of the Streets, that's it. Havoc of the Streets. And so there's a whole like section, but Inspiring Youth right now has to be referred by the police. I just talked to them. However, they are working to have referrals, and I think have coming from the clinic would be a great, they work with, I think, 10 to 17-year-olds. Restoration Incorporated.
Thank you so much.
Connie, you should have good panel. Sure, there's someone back there's again.
Thanks so much for your time. I have 5,000 questions, but I have one that's very specific to my job, so I apologize for not very quick. My last year of surgery residency at the U, we work at North Memorial and at Regents. And I was thinking about the other people that are involved in the trauma activations that are not healthcare providers, and ways that I can grow in that. And two people that come to mind are family members, as you mentioned, the community members, and police. And the community members, or family members that are there, in medical school, it's all about protecting patients' privacy and trying to make sure that we're not disclosing information to people that have not been explicitly allowed to hear that information. So trying to think in my mind about a balance of comforting family that is in an understandably panic mode while honoring the patient's privacy. And if you have any tips for that. Secondarily, there is always a police presence. There's a gun violence event in an emergency room, and I've always felt quite uncomfortable about that in terms of wanting to always show allyship with the patient, to not further, you know, you get asked a lot of questions by police too, and trying to make sure that I'm first and foremost advocate for my patients, no matter what their role is in the situation. So I'm just wondering if the panel or anyone else had any comments about those things and how we could be better.
Yeah, I mean, I would agree for the family showing up, if the patient is not, coherent or can't identify who's going to get up. It's when family is showing up, how can we start working with the family to get identifiers to make sure we know that that's the right patient that we're talking about. That's one way, and we just did that Tuesday. Because sometimes, like a cousin showed up who was at the scene taking care of his dying cousin, and they show up and they follow the ambulance to the hospital, and then the hospital makes them no info, and then they're showing up, and then we're telling them that they're not there. That's again, we're re-traumatizing, even though they followed the ambulance to the hospital, and the police said, come to HCMC, because that's what we're taking them, and we get there and say, no, they're not here. So yes, we have to figure out a better way, and I think a better way is to go out there and have a conversation with them and start saying, can you identify the tattoos or birthdays or any kind of physical feature? As far as police in the emergency room, I would agree with you. Because that's what we've been working with our hospital, because we would just take all the belongings, give them away, let the police stay in there even after work was done. So some of our physicians have started to take the position of asking the police to wait outside if the work is done. And I think it's going to take the leadership of whoever's running the stabilization room to say, if your work is done, can you please step outside of the hospital, because the patient has rights too.
I'll have that conversation with the police chief.
As a resident, unknowingly, I was part of that problem. And in my mindset was more of I didn't know where this things went afterwards. I thought just like somebody that needs surgery gets put into a bag and brought up, and then they get it eventually. And so I was probably diligently not helping police more than I thought I was, because I didn't want them to lose stuff. So I'd be part of the trauma evaluation is exposing, removing belongings to fully evaluate injuries. And I would take things that I didn't want to get swept aside or thrown in the trash, because socks generally get thrown away and not kept. And if they had money or wallet, I would make sure that made it into that bag, because I thought if it was there, it was safe. And that was, eye-opening. With Contrell and I have had conversations about what should stay with the patient and what police actually need or think they need. And so I've been part of that problem. And so I think that helps me right now be a better advocate for making sure that that's not continuing, and again, being the advocate for next step down in our trauma bay and trying to propagate that through our department, to say something in our position as leaders down in that emergency department.
So it's 7:30, and I know there's a lot more questions out there, and there's a lot of welcome knowledge in the audience too. Just gonna give the last final words, if anything you want to make any last remarks, otherwise, chance for people to network and connect. Again, so much welcome knowledge.
I think I've said and shared more today than I have with my wife about this topic. I appreciate everyone being here, and as I'm learning more and more every day, just thankful that there's other people that are starting or midway or advanced their journey, both the common cause.
I'm going to echo that mosquito net metaphor. I'd never had intentions of running for office. I wasn't one of those like poli-sci kids that always wanted to be in public office. I just, the moment was the moment, and but you don't have to run for office to make a difference. I think you just have to decide that you want to make a difference, and then you can find out where you can do that. And that's anything from what you do with the patient's belongings at the moment and making a different choice there, all the way through to, making sure that we have different legislation passed at the state. So you have a role to play. Oh, and I really want to highlight, like, send a letter to your legislator. I'm serious. I get a lot of email, and it makes a big difference when you're getting hundreds of emails on a topic. You don't normally get hundreds of emails on a topic. And so when you do get hundreds of emails, like, if everybody in this room sent a letter to your legislator, like, it makes people's eyes pop out, and it's actually kind of shocking how much people don't realize them doing direct outreach to their elected people actually works. Like, it's literally our job to read that email and take it seriously, so like, send that letter.
Yeah, I would agree. I would say, like I said, it's been my mission to stop saying, folks who are survivors of violent crimes, victims. I would say this mission started to were survivors. And I would say too, like everyone, you do have a part to play. I would say, be interrupters with the rest of us. Let's disrupt the system, because we don't have to live with this. We can live better. We don't have to have our kids out there dying because they pushed the wrong doorbell and went the wrong driveway. We don't have to live that way.
Thank you so much. Thank you very much. Opportunity to network, connect, learn from each other. You're welcome to stay if you want to hang out and go home and hang out with your family. Please do that too. So, okay. Out of my heart, thank you so much. And yes, write that letter. Maybe that's myself. So. I